when you look at a comprehensive metabolic panel, there's usually this comforting expectation of certainty, you know?
Right, like it's a definitive answer.
Yeah, exactly. You read it like a bank statement. If you see like a low potassium level, you just replace it.
Yep.
Or if the sodium is climbing, you adjust the patient's fluids. It feels entirely binary and,
Yep.
well, objective.
It does, but that's not always the case.
No, not at all.
Yeah.
Because then you look one line down at the serum calcium, and that comforting certainty completely vanishes.
Oh, it really does.
You essentially step into this diagnostic landscape that operates entirely on medical illusions, where a perfectly normal number can belong to a patient who is actively crashing, and an alarmingly low number might mean absolutely nothing at all.
Which is terrifying if you don't know what you're looking at.
Right. So today we are taking a deep dive into the human nervous system for you. We're looking at the telltale signs of calcium imbalance.
And it's really a medical detective story, honestly.
It really is. We're going to untangle the modern critical care debates surrounding it and explore how a few, 19th century bedside tricks are literally still dictating modern medical protocols today.
Because, we're so conditioned to trust the numbers on the screen.
Yeah, totally.
We treat them as empirical reality.
Yeah.
But calcium forces you to question the methodology behind the number.
Which is hard to do in a fast-paced environment.
Exactly. If you just take the lab value at face value, without understanding the physiological state of the patient sitting in front of you, you are going to make critical errors.
Okay, let's unpack this. Because the trap starts with the very definition of what we're actually measuring.
Right.
Let's say I'm looking at a critically ill patient, maybe someone septic in the ICU, and their total calcium comes back at 7.2.
Which is low. The normal range is 8.5 to 10.5 milligrams per deciliter.
Right, so 7.2 is low. The instinct is to panic and push IV calcium.
Right, of course it is.
But that total calcium number is hiding this massive structural division in how the mineral actually exists in the blood.
It's hiding the fact that total calcium is essentially a composite score of 3 completely different compartments.
Okay.
And only one of those compartments actually matters to the patient's immediate survival.
Only one.
Yeah, just one. So roughly 40% of the calcium in the blood is tightly bound to plasma proteins.
Mostly albumin. Right?
Predominantly albumin, yeah. And then another 10% is complexed with anions, things like phosphate or citrate.
Okay, so that's half of it right there.
Exactly. That leaves only about 50% existing as free ionized calcium.
And the ionized portion is the only part doing the actual physiological work,
Right, it's the active part.
I actually like to think about this in terms of personal finance.
Oh, I like this analogy.
Yeah, so imagine a patient's total serum calcium is their total net worth.
Okay.
40% of their money is locked away in an untouchable trust fund.
Ah, the albumin-bound calcium.
Exactly, they cannot spend it. The 50% that is ionized is their liquid cash.
The money in their checking account?
Right. That's what they use to pay the daily bills.
Mm.
Firing nerves, contracting muscles, clotting blood.
All the vital stuff.
Yeah. So if I have a septic patient whose liver has stopped producing albumin, their trust fund is basically empty.
Their net worth looks terribly low on paper.
Exactly. Their total calcium is low. But if I actually measure their liquid cash, their ionized calcium, it might be perfectly adequate.
That analogy hits the absolute core of the problem.
Because you could overcorrect, right?
Right. If you look at that artificially low total calcium and immediately push an IV replacement, you are treating a ghost.
Oh, wow, yeah.
You risk driving their true ionized calcium dangerously high.
Which is hypercalcemia.
Exactly. Now, for decades, the medical workaround was to use the corrected calcium formula.
I've heard that.
Yeah, clinicians would take the total calcium lab value and mathematically adjust it based on the patient's albumin level.
Basically trying to guess the liquid cash based on the size of the trust fund.
Right, attempting to estimate the true physiological state.
But if you talk to nephrologists or intensivists today, they act like the corrected calcium formula is practically a relic.
Oh, they hate it.
Why has it fallen out of favor if it supposedly accounts for that albumin drop?
Because the formula assumes a static relationship.
Yeah.
And, well, critical illness is anything but static.
That's constantly changing.
Exactly. The affinity of albumin for calcium isn't fixed. It changes based on the patient's blood pH, their temperature, and even the presence of medications like heparin.
Wait, really?
Yeah. If a patient hyperventilates and becomes alkalotic, for example, their albumin suddenly binds calcium much more aggressively.
Oh, so it steals it from the ionized pool.
Yes, it literally locks up the liquid cash. crash.
Wow.
And the formula cannot account for those dynamic, real-time shifts. Relying on it in a complex ICU patient is essentially just guessing.
So what do they do instead?
That is why the modern gold standard is to bypass the total calcium entirely and measure the ionized calcium directly via a blood gas analyzer.
It is fascinating that such a foundational question like, is this patient's calcium normal, requires you to bypass the standard metabolic panel entirely.
You just can't trust it.
But if we isolate that liquid cache, that ionized calcium, we have to look at what it actually does at the cellular level.
A physiology.
Right. Because I always pictured calcium as an excitatory mineral.
Most people do.
You think of it flooding into muscle fibers to trigger a contraction. But in the nervous system, it actually acts as a brake, doesn't it?
It acts as the ultimate gatekeeper.
The gatekeeper.
Yeah, the clinical picture of calcium imbalance basically revolves around the excitable cell membrane.
Okay, picture that for me.
Picture the cell membrane of a peripheral nerve as a wall lined with voltage-gated sodium channels.
Like doors in the wall.
Exactly. The ionized calcium sits on the extracellular surface of those channels.
Just hanging out outside the door.
Right. Because calcium is a divalent cation, meaning it has a positive 2 charge, its physical presence alters the electrical threshold required for that sodium channel to open up.
Oh, so it literally stabilizes the membrane. So if the ionized calcium drops, if you develop hypocalcemia, you lose the gatekeeper.
You completely lose the gatekeeper.
Yeah.
And the threshold for depolarization just plummets.
The doors swing open?
Yes. Those sodium channels open with almost zero provocation. Sodium rushes into the cell, and the nerve fires spontaneously.
Wow.
The entire nervous system becomes wildly hyperexcitable.
Here's where it gets really interesting, though.
Oh, yeah.
Wait, so if low calcium makes nerves fire spontaneously, is that why patients get that random tingling around their mouth?
Yes, exactly.
Because a lot of times the patient will complain of a weird tingling around their mouths or maybe numbness in their fingertips.
The classic early sign.
And it's incredibly easy to dismiss that as anxiety.
Oh, it happens all the time.
You think, oh, they're just stressed, maybe hyperventilating.
But those early paresthesias, the perioral and acral tingling, are the sensory nerves literally misfiring because the calcium brake has been removed.
That's incredible.
And dismissing that tingling is a massive clinical pitfall.
It's not just anxiety.
No. It is the absolute earliest warning sign of impending tetany.
Which is bad.
Very bad. If that hyperexcitability is allowed to escalate, it moves from the sensory nerves to the motor nerves.
So the tingling turns into actual cramping.
Right. Tingling turns into muscle cramping, then overt spasms, and eventually full-blown seizures.
Man.
It even destabilizes the cardiac conduction system. It physically prolongs the QT interval on an ECG, which sets the stage for lethal arrhythmias.
And I assume the physiology works in the exact opposite direction, too.
It does.
Like, if low calcium removes the brake and makes everything hyperexcitable, hypercalcemia does the reverse.
It overstabilizes the membrane.
It puts too many guards at the door.
Exactly. The sodium channels become stubbornly resistant to opening.
So what does that look like clinically?
The clinical result is profound sluggishness.
Okay.
Patients present with severe lethargy, muscle weakness, deep confusion, and in extreme cases, coma.
Because the nerves just won't fire.
Right. And the heart's electrical firing is rushed, leading to a shortened QT interval.
Once you understand the biophysics of that sodium channel gatekeeper, every single symptom you see at the bedside makes perfect logical sense.
It really does. But what's amazing is that clinicians figured this out long before they knew any of that science.
Yes. Because long before anyone had mapped out voltage-gated sodium channels or understood the physics of cell membranes, clinicians were observing this exact hyperexcitability in real time.
It's wild.
Clinical pattern recognition completely outran basic science by decades.
We really have to look back to 19th century Europe.
Right.
In the 1860s, nobody knew what serum ionized calcium was. Basic endocrinology didn't even exist.
They were just looking at symptoms?
Exactly. But physicians observed a terrifying neuromuscular irritability syndrome they called tetany.
And they started figuring out ways to provoke it diagnostically.
Yeah, the most famous example being Armand Trousseau.
Oh, the French internist.
Right, working in Paris in 1861.
He noticed something bizarre.
He did. If he occluded the blood flow in a patient's arm, sometimes just incidentally by applying a tourniquet to draw blood, it triggered an incredibly specific involuntary spasm in the patient's hand.
The characteristic obstetrician's hand.
Yep. The fingers forcefully extend, the thumb adducts tightly into the palm, and the wrist flexes inward.
It looks so painful.
Trousseau realized that inducing ischemia in the arm exacerbated the underlying nerve irritability.
Because the nerve was already primed to misfire because of the low calcium, right?
Exactly, though he didn't know the calcium mechanism at the time.
Right.
And cutting off the blood supply just pushed it over the edge into a visible spasm. He named this a marker for latent tetany.
But there's a detail in Trousseau's biography that is just wild to me.
Oh, the two signs.
Yes. Nursing and medical students are constantly warned not to confuse his signs because Trousseau's name is actually attached to two completely unrelated medical phenomena.
It's a classic exam trick.
Right. There's Trousseau's sign of latent tetany, which we just discussed,
Oh.
but there is also Trousseau's sign of malignancy.
Yes, migratory superficial thrombophlebitis.
Right.
It is a blood clotting disorder that frequently acts as an early warning sign for hidden visceral malignancies, particularly pancreatic or gastric cancer.
And Trousseau discovered both of these.
He did.
But the dark irony is that in 1867, just a few years after publishing his work on the tetany spasms, Trousseau developed unexpected blood clots in his own leg. He found the second sign on his own body.
He actually used his own discovery to...
Wait, he diagnosed himself?
He did. He used his namesake discovery to correctly self-diagnose the gastric cancer that ultimately killed him a few months later.
Wow, that is a profound, if tragic, piece of medical history.
It really is. What's fascinating here is how it serves as a reminder of how heavily early medicine relied on the astute physical exam.
Pattern recognition.
Exactly. And Trousseau wasn't alone. In 1876, an Austrian surgeon named Franz Chvostek identified another mechanical trigger for tetany in Vienna.
Oh, Chvostek's sign.
Right.
Chvostek found that if you simply tap on a patient's facial nerve-like, right in front of the earlobe, below the cheekbone, the facial muscles will involuntarily twitch.
Just a little tap?
Yeah, sometimes just the corner of the mouth, sometimes the entire side of the face pulls upward.
And again, he didn't know the basic science.
He just recognized the pattern of the hyperexcitable nerve.
Right. And what's fascinating here is how these 19th century observations transitioned into the modern era.
Because we still use them.
We do.
Right.
Today, we understand the exact molecular mechanisms behind them, yet Trousseau's and Chvostek's signs remain standard physical exam techniques taught in every medical and nursing school.
But their utility in a modern hospital room is highly debated.
Oh, heavily debated.
Because they are not equally reliable. It creates this massive bedside dilemma.
This raises an important question about shortcuts in medicine.
Yeah, let's start with Chvostek's sign. It is incredibly appealing because it is so easy to perform.
It takes 2 seconds to tap a patient's cheek.
Exactly. But you look at the modern data, and Chvostek's sign has a terrible false positive rate.
Very high.
Something like 10% of people with perfectly normal calcium levels will twitch if you tap their facial nerve.
So the specificity is incredibly poor.
Right.
If you get a positive Chvostek sign, it does not confirm hypocalcemia.
It just means you need to check.
Exactly. It simply mandates that you draw the patient's blood and check an ionized calcium level. It is a screening tool, not a diagnostic one.
But Trousseau's is different.
Right. Trousseau's sign of latent tetany, conversely, is highly specific.
Right.
If you induce that distinct carpal spasm, the statistical probability that the patient has true hypocalcemia is overwhelming.
But the execution of Trousseau's sign is where the problem lies.
It's not easy.
No, you can't just tie a quick tourniquet like you did back in the day.
Right, the modern protocol is stricter.
The protocol requires you to inflate a blood pressure cuff above the patient's systolic pressure and hold it there, cutting off the arterial blood flow for a full 3 minutes.
And 3 minutes of arterial occlusion is intensely uncomfortable.
I can't even imagine.
Yeah, particularly for a patient who is already sick, distressed, or, recovering from surgery.
It perfectly illustrates the classic shortcut problem in clinical medicine.
It really does.
The test that is easy to do, the cheap tap, is the one you can't fully trust.
Right.
But the test you can trust, the 3-minute blood pressure cuff, is the one clinicians are tempted to skip because it causes the patient distress.
But skipping these assessments is dangerous.
Because these calcium shifts aren't theoretical.
No, they happen constantly in specific clinical scenarios.
So where do we actually see this?
Well, the context of the patient dictates your index of suspicion.
Okay.
The most notorious trigger for acute hypocalcemia is thyroid surgery.
Oh, right.
A patient undergoes a total thyroidectomy to remove a malignancy. The surgeon has to navigate around the 4 parathyroid glands, which are tucked directly behind the thyroid capsule.
And these glands are microscopic, right? They're about the size of a grain of rice. And their vascular supply is incredibly fragile.
Extremely. They share a blood supply with the thyroid itself.
Okay.
So even if the surgeon meticulously preserves the parathyroid glands, the microvasculature is easily bruised or temporarily devascularized.
They just get stunned.
Exactly. And those 4 tiny glands are the sole producers of parathyroid hormone, or PTH.
Which is the primary engine the body uses to mobilize calcium into the blood.
Right. If they are stunned during surgery, PTH production halts and the ionized calcium crashes within hours.
That perfectly explains why post-thyroidectomy protocols are so strict.
You have to watch them like a hawk.
You are checking labs and doing bedside assessments for Chvosteks and Trousseaus every few hours.
Yep.
But there is another trigger that surprised me, mostly because of how mechanical the problem is.
Which one?
Massive blood transfusions.
Oh, yes.
Let's say a trauma patient is bleeding out, and they're receiving unit after unit of packed red blood cells. They can develop severe hypocalcemia rapidly.
That is a classic iatrogenic mechanism.
Meaning we cause it, essentially.
Basically, when blood is collected and stored by a blood bank, it is mixed with a citrate solution to prevent it from clotting in the bag.
Right.
Citrate works precisely by binding to calcium.
Because calcium is needed for clotting.
Exactly. When you transfuse that blood into a patient, their liver normally metabolizes the citrate into bicarbonate without any issue.
But if you are doing a massive transfusion, you are just overwhelming the system.
You completely overwhelm the hepatic clearance.
Wow.
Particularly because a trauma patient in hemorrhagic shock has poor perfusion to their liver anyway.
So the liver isn't even working at 100%.
Right. The citrate accumulates in the bloodstream and instantly chelates or binds the patient's circulating ionized calcium.
It just sponges it all up.
Yes. Suddenly, the patient is not only bleeding, but their heart muscle is losing the calcium it needs to maintain a strong contraction.
Which leads to severe hypotension and potential arrhythmias.
It's a cascade. It requires clinicians to anticipate the drop and proactively push IV calcium alongside the blood products.
Okay, so those are the classic avenues for a calcium crash.
Right.
Let's pivot to hypercalcemia, when the calcium climbs too high. The sources point out a really distinct diagnostic split depending on where the patient is located when the high calcium is discovered.
Oh, the location completely dictates your diagnostic algorithm.
Okay, how so?
If you see hypercalcemia in an ambulatory outpatient, like someone who just walked into a primary care clinic for routine lab work, the overwhelming statistical probability is primary hyperparathyroidism.
Which is what exactly?
Usually this is a single benign adenoma on one of the parathyroid glands that is autonomously secreting too much PTH, completely regardless of the blood calcium levels.
So it's just pumping out hormone when it shouldn't.
Exactly. But if that hypercalcemia is discovered in a patient who is already admitted to the hospital, the most likely cause completely flips.
Right. It's not the benign adenoma anymore.
No. In a hospitalized population, hypercalcemia is overwhelmingly driven by malignancy.
Cancer.
Yes. It could be a tumor secreting a peptide that perfectly mimics PTH, confusing the body.
Wow.
Or it could be osteolytic metastases cancer cells that have spread to the bone and are actively destroying the bone matrix, releasing massive amounts of calcium into the circulation.
Man, that's heavy. But you know, you cannot talk about hypercalcemia without diving into milk alkali syndrome.
Oh, the history of this is incredible.
It is one of the most bizarre medical plot twists.
Truly.
Back in the early 20th century, the standard treatment for peptic ulcer disease was this thing called the sippy diet.
Right.
Doctors had patients drink massive, continuous quantities of milk and absorbable alkali powders, like calcium carbonate.
Because it worked. It was an effective way to neutralize stomach acid before the invention of modern pharmacology.
Right, but it flooded the gastrointestinal tract with so much calcium that it caused a toxic triad.
Severe hypercalcemia, metabolic alkalosis, and acute kidney injury.
But then we invented modern acid-suppressing drugs.
Yeah.
You know, H2 blockers and proton pump inhibitors.
Thank goodness.
Right. The sippy diet was abandoned, and milk alkali syndrome basically went extinct.
You couldn't find a case of it in the medical literature by the 1980s.
But today, Shit is back.
It is.
And it hasn't been brought back by a new disease. It's been resurrected entirely by modern consumer wellness trends.
Yep. The aggressive marketing of over-the-counter calcium carbonate supplements for bone health and osteoporosis prevention has led to this culture of inadvertent overdosing.
People just think, oh, it's natural.
Exactly. Patients assume that because calcium is a natural mineral, more must be better.
Right.
They take heavy doses of calcium supplements, combine them with over-the-counter antacids for indigestion, and add high-dose vitamin D.
Oh, no.
They are perfectly recreating the sippy diet conditions from a century ago.
That's wild.
They develop the exact same toxic triad and end up landing in the emergency department with renal failure.
It just highlights this dangerous misconception that supplemental nutrition is inherently risk-free.
It's not.
It's just wild that a disease eradicated by medical advancement was resurrected by a marketing campaign.
If we connect this to the bigger picture, it really proves how interconnected and unforgiving the entire endocrine system is.
Everything affects everything.
Yes, you cannot view calcium in a vacuum. We've discussed PTH and vitamin D, but there's a silent partner operating behind the scenes that dictates everything.
Magnesium.
Magnesium.
Magnesium. Why is it that you can't fix a calcium imbalance without looking at magnesium first? Does it bind to the calcium in the blood?
No, it doesn't bind to it. It regulates the regulators.
Okay, what does that mean?
Magnesium is a required intracellular cofactor for the parathyroid glands.
Okay.
In order for the glands to package and secrete parathyroid hormone, they literally need magnesium.
So no magnesium, no PTH.
Exactly. If a patient is severely deficient in magnesium, it physically paralyzes the parathyroid glands.
Wow.
Furthermore, the peripheral tissues become resistant to whatever little PTH is circulating.
So you could have a patient actively seizing from hypocalcemia, and you could push intravenous calcium all day long, but it won't work. It won't hold. Because the body can't retain it in the blood, because the control mechanism is paralyzed.
Right. You have to infuse magnesium to wake up the parathyroid glands before the calcium gatekeeper can actually do its job.
So what does this all mean? We started with the illusion of the standard lab panel, explored how ionized calcium operates as the crucial gatekeeper for every nerve in your body, traced the history of Trousseau's 19th century tourniquet, and ended up at the intersection of modern wellness trends and hidden magnesium deficiencies.
It's quite a journey.
The physiological mechanics are fascinating, but the clinical stakes are just incredibly high.
The stakes are exactly why understanding this is a mandatory competency.
Yeah.
Missing these signs is universally categorized as a preventable harm.
Because we know what to look for.
Exactly. If you brush off a patient's tingling lips as anxiety, it can progress to laryngospasm.
Which is when the vocal cords lock shut, right?
Yes, the vocal cords lock shut and the airway is lost.
Terrifying.
And on the flip side, we must abandon the notion that hypercalcemia is always glaringly obvious.
Right, because of the rhyme.
Yeah, medical students memorize that classic rhyme. Stones, bones, groans, thrones, and psychiatric overtones.
Meaning kidney stones, bone pain, abdominal cramps, polyuria, and confusion.
Right. But waiting for a patient to develop bone pain and profound confusion means you've completely missed the window.
That's too late.
That rhyme only applies to late-stage severe hypercalcemia. Mild hypercalcemia operates completely silently.
So you wouldn't even know.
It is an insidious process. It is why we rely on routine laboratory screening, provided we actually understand how to interpret the numbers we are looking at.
The ionized cache.
Exactly. And, examining this delicate balance leaves me with one final thought, specifically regarding vitamin D.
Which is the primary driver for absorbing calcium from our diet in the first place, right?
Precisely. We know that vitamin D deficiency is one of the most common causes of hypocalcemia globally.
Okay.
Human physiology coordinates this extraordinary dance between the bones, the kidneys, and the gut to keep our ionized calcium locked into a microscopic, highly protected window.
Right, a very tight range.
But consider our modern environment.
Okay.
We now spend the vast majority of our lives indoors, heavily shielded from the sun, fundamentally driving our baseline vitamin D levels down across the entire population.
Oh, wow. I see where you're going with this.
Right. The system is designed for an environment we no longer live in.
We don't live outside anymore.
We don't. As our environmental exposure drastically shifts over decades, this raises an important question. Could the very definition of what human biology considers normal calcium regulation be forced to evolve?
Wow, that is a brilliant question to end on. It totally reframes how we look at the boundaries of human physiology.
It really makes you think.
It does, and it reminds us that that comforting certainty we expect from a simple blood test might just be the most convincing medical illusion of them all. Thank you so much for joining us on this deep dive. Keep questioning the numbers, look for the mechanics behind the symptoms, and keep exploring the world around you.